Hello dear students, so in this video we are going to look at one very important topic, scabies, which is very important from theory exam point of view. So myself Dr. Maddineni Srinivas, welcome to my YouTube channel. If you are new to this, please do hit that subscribe button to follow more such dermatology videos on a regular basis. So this you can see the scabies, all about scabies is very important. So we are going to discuss about the same in this video, Norwegian scabies and what are the medications, clinical features, etiology diagnosis, everything we are going to see. And after watching this video, I would suggest you to read any of these books so that you can easily reproduce whatever you have learned or listened in this particular video. Okay, so let's begin the discussion with the etiology. What is the causative agent? It is Sarcoptes scabies, which is a mite, which is a ectoparasite which lives on the skin surface. Okay, so these are the points which are must to know, very important points. That is Sarcoptes scabies, which is a mite and it is also called as itch mite. And if you can draw in the exam, so whenever you have a possibility, I would suggest you to just draw a small line diagram also at least. So this is the actual picture of the itch mite and you can simply draw like this, which is having two pairs of anterior legs and two pairs of posterior legs, and here is the face. So if you can draw like this, then the examiner will get impressed. Okay, this student knows about this condition and also knows how the organism looks like. Okay, so now coming to transmission, how is this condition scabies transmitted? So please remember, it is very important. Direct skin to skin contact is the major route of the entry of this parasite from one person to another, and indirectly through the clothing, bedding and linen. Okay, so these are all put together, they are referred to as fomites. The clothing, bedding and the linen, inside them this mite can survive for a period of 24 to 36 hours. Okay, without food and the water. Okay, now coming to the what is the pathogenesis. So basically this female mite, just like every problem is due to the females. Okay, so I'm just kidding. In the microbiology, you might have read the female mosquitoes are the ones which will bite, and likewise here in dermatology, female mite is going to burrow in the epidermis. Specifically in the epidermis, it is going to be the stratum corneum, which is the superficial most layer, and it will lay the eggs and it will die there itself in the stratum corneum. So this is the itch mite which you are able to see here, which is making these tunnels inside the skin. This is the tunnel in the stratum corneum, and you can see these are all the small babies which are following the mother mite. So this cycle continues as larvae hatch and reproduce. This will go on and go on inside the stratum corneum, and ultimately what happens is the patient's body is going to mount a hypersensitivity reaction, which is type 4 hypersensitivity reaction, basically to the mites and the feces and also X. And because of this hypersensitivity reaction, there are going to be certain symptoms which we can see. So in the clinical features, so remember one very important point, or we can say buzzword, which is called as burrow. Burrows are the serpiginous tunnels which are clinically seen on the skin surface because of this mite which is burrowing, that is making the tunnels inside the skin. Okay, so this burrow, it is a pathognomonic lesion of scabies. Pathognomonic lesion of the scabies, and clinically we can see this as a serpiginous snake-like tunnels, and this can be asked as a MCQ also, so please do remember this. And in the symptoms, primary symptoms, remember the most important symptom and most irritating symptom is itching, and that itching is also going to be worse at the night time. So this itching is also referred to as, nocturnal itching. Nocturnal is nighttime itching. And what else we can see on the patient's body? We can see red colored small raised papular lesions and sometimes even excoriations because of the constant scratching, and crustings can also be seen. And like I have told you, pathognomonic lesion is the burrow, which is the serpiginous tunnel. which is made by this mite. And coming to the distribution, where are these lesions predominantly present? Just remember, so in the web spaces, in the wrist, in the antecubital fossa, in the axilla, and in the nipple area, and in the umbilical area and the groin. So these are all the areas where the lesions are going to be predominantly present and itching is going to be predominantly present. And all these areas put together, it forms a circle. It forms a circle, and this is called as circle of Hebra. Very important, circle of Hebra. If you can write these buzzwords in the exam, then the examiner will get impressed and they are going to give good marks. So web spaces, the wrist, antecubital fossa, axilla, the nipples, the umbilicus and the groin. So all of them put together, they form a imaginary circle and it is called as a circle of Hebra. So these are the sites where the lesions are predominantly seen. And remember, in the case of children, palms and soles and scalp may be affected, and also remember face can also be affected in the case of the children. Just remember one point, dear students. So in the case of the children, the face has sebaceous glands, but the sebum is not going to be secreted until they attain the puberty. That is number one point which all of you know. And remember, sebum has anti-scabetic properties. Sebum has anti-scabetic properties. Anti-scabetic properties. So that is the reason why in the adults, this mite is not going to live on the face. It will not live, it is going to be killed because of the sebum which has anti-scabetic properties, whereas in the children, the face can also be involved and face can also have the papular lesions and the excoriations and the itching. Okay. And remember, rarely, very rarely, the adult's head can be affected. But remember, students, in the case of the adults, in adults, broadly you can remember adults, face, palms and soles. All these areas are completely spared without any lesions. Face, I have told you why it is spared, because of the sebum which is produced from the puberty. Why are palms and soles spared? Because palms and soles, the adults are going to do some or the other work, because of which the mite is going to get dislodged, because of which there will not be any kind of lesions on the palms and soles. And what could be the complications of this scabies? Just remember, because of the constant scratching, itching of the body, there can be secondary bacterial infection due to the bacterial staphylococcus or streptococcus. Okay. So next, coming to one important type of the scabies, which is Norwegian scabies. It is also called as crusted scabies. Okay, so what do you mean by Norwegian or crusted scabies? So I hope all of you know what do you mean by a crust. Crust is the serum pus or blood. Okay, whenever it gets solidified, dried up on the skin surface, we call it as a crust. So in the case of the Norwegian scabies, we are going to see the presence of the crust on the body. So I will just show you the picture so that you will get understanding of this. You are able to see this picture which from the side angle of a patient's trunk. Okay, this is entire trunk. You are able to see that the trunk is covered by very thick hyperkeratotic plaques. Okay, all over the body, all over, almost entire body will be affected like this, and the entire body is going to be having hyperkeratotic plaques in the case of Norwegian or crusted scabies. And this is the hallmark of the crusted scabies, and it is the severe variant, very severe variant of scabies, and it is usually seen in the patients who are having immunocompromised status. Like for example, they may be on chemotherapy, or they may be HIV individuals, or if the patients are having leprosy. Okay, then also there is a high chance of development of crusted scabies in those individuals. Okay, so what is the reason behind this presentation. So just let me tell you one simple concept. In the normal individual, if a scabies mite is present, the uh, reaction of the body is going to be in the form of itching. Okay, there will be itching in normal individuals. Because of itching, what happens? Itching is actually very good for a given patient, normal person. Why? Because of this itching, what happens? There will be dislodgement of the mites from the body, and they will go into the environment. The reproduction of the scabies mite will be reduced in the skin surface. Okay, that is the reason why in normal individuals, okay, in normal scabies, the number of the mites are going to be just 10 to 15 mites in a given person. Whereas in the Norwegian scabies, what happens? Because of the reduced immunity, or because of reduced sensations, okay, reduced sensations, as we can see in the patients of leprosy. Okay, this is very important. So in the patients of leprosy, because of the reduced sensations, itching sensation will not be there, itch sensation will not be there, pruritus will be very minimal. Remember, scabies is equal to itching is the hallmark of scabies, but in the Norwegian scabies, itching will be very minimal. This is very important point. If you can write this, the examiner will be impressed, very much impressed. And that is the reason why Norwegian scabies, the number of the mites is going to be millions. There will be millions of mites in a given patient. Okay, and remember, there is one dreaded complication of the Norwegian scabies that if you can remember, that is going to help you to get the extra marks. Erythroderma. The development of the erythroderma is possible in the patients of Norwegian scabies. What do you mean by erythroderma? Erythro is red, derma is skin. So almost 90%, more than 90% of the body surface area of the skin is going to be erythematous and also associated with scaling, So if these features are seen in a given patient, we call it as an erythroderma, and Norwegian scabies is one of the important causes for erythroderma. Okay, I hope you have enjoyed till this point. So we are going to see the management. So if you like this video, please do hit that like button so that I will get to know that you are enjoying this video presentation. Okay, so coming to the diagnosis, how to diagnose a condition. So it is mainly clinical diagnosis. So like I have told you, two very important points. In the clinical history, there should be a mention of nocturnal itching, that is night itching. And also one more very characteristic finding which you should ask is the similar history of similar complaints in the family members or in the contacts. So this is very important. Similar history in family, or if they are staying in any PG or hostel, then the contacts will also be having similar complaints, because this might can get transmitted from one person to another person through skin to skin contact, or even through the fomites, that is the DrUHS. And of course, the identification of the burrows is one more important pointer towards the diagnosis. So basically you can see here both these things are clinical. Apart from this, for confirmation, we can scrape these burrows and put it over the glass slide and see under the microscope for the presence of this mite. Okay, so these are all the diagnostic techniques. Next is, how is the management done? So in the management, you should remember that there should be general measures. In the general measures, you should write down that the patients, whoever are going to have this scabies, they are going to get the treatment. Apart from this, the contacts, okay, the family members, and also any sexual contacts, if they are there, they also need to be treated, even if they do not have any symptoms, but still we have to give the treatment to family as well as sexual contacts or close contacts. Otherwise, what happens? We give the treatment for the patient is going to get cured, but the patient is again going to be reinfected from the other family members, because this might will be there in the other family members, which can easily reinfect this patient, index case. Okay, so this is a problem. So to prevent that, general measures, remember, treat the family and also sexual contacts. And also you can remember, because this can transmit from the clothes need to be washed separately. Ideally, if they are treated in the hot water, that is better. Okay, so these two are the general measures. So coming to the specific treatment modalities, so eradication of the mites, topical agent, remember there are so many topical agents. So Permethrin 5% cream, it is the drug of choice in the case of the scabies. Okay, it should be applied over entire body and repeated after 1 week. What are the alternatives? So there are so many other topical preparations. So benzyl benzoate, lindane, which is also called as gamma benzene hexachloride, and apart from that, sulfur and crotamitone. So these are all the topical agents which are available. So I will show you how they look, the brands and all also in the next slide. So next, coming to the ivermectin, remember, a single dose of 200 micrograms per kg. Okay, dose of the ivermectin are repeated after 2 weeks. So one tablet should be given today, another tablet should be given after 2 weeks. And what is the dosage? It is approximately 12 mg for a 60 kilogram individual, that is 200 micrograms per kilogram. And remember, because Norwegian scabies is a severe variant of the scabies, here we are going to use permethrin, along with that we are going to give ivermectin as a combination. Okay, so this is one difference. Otherwise, in the normal scabies, even if permethrin is used or if oral ivermectin is used, the treatment will be completed. But in the case of Norwegian scabies, treatment is little bit aggressive. So we'll combine ivermectin and also topical permethrin. To control the itching, the symptoms, so we are going to use the antihistamine cetirizine. Okay, and if it is severe, we can also use topical or oral steroids. Okay, so these are all the topical and oral preparations which are available: benzyl benzoate, gamma benzene hexachloride, permethrin, and you can see crotamitone. So this is the ivermectin, which is the only oral medication which is available and indicated for the patients of scabies. For secondary infection, if there is a bacterial infection, systemic antibiotics can be given. Okay, and like I have told you, prevention and the transmission control, treat all household members and also the close contacts, decontaminate the clothing, hot wash and dry, and isolate and manage Norwegian scabies. So Norwegian scabies patients should be admitted and treated very carefully, otherwise they can transmit the infection to rest of the others also. Okay, so you can see these are the pictures. So here you are able to see in the web spaces, there are small pustular lesions which are present, and here you can see this is looking like this cute tortoise. Okay, but tortoise has one pair of anterior and posterior legs, whereas the scabies mite, it is going to have two pairs of anterior and posterior legs. And of course, KOH mount of the skin scraping has to be done, and it is observed under the microscope. Okay, yeah, so now some fill in the blank type of question. Pathognomonic lesion in the scabies is, so these can be expected MCQs for your theory exam. So you should know burrows are the pathognomonic lesion of scabies. These were already asked. A patient presented with lesions in the interdigital clefts. Oral drug which is used in these patients is going to be ivermectin. Okay, so incorrect about the adult scabies. Okay, burrows are pathognomonic, absolutely true. Itch mites burrows into the stratum corneum, absolutely correct. High yield lesions on the face and palms, this is incorrect statement. Ivermectin blocks the glutamate driven chloride channels, and by this it is going to produce paralysis of the scabies mite. That is also correct. So answer here is option C. So this type of question may be asked in the, if it is by mistake asked as a long answer question, this could be a case-based scenario where you can see a 7-year-old intellectually disabled boy brought with large warty crust on the trunk, hands and feet. Severe fissuring and scaling of the skin is noted. What is the possible diagnosis? Okay, so intellectually disabled, so what does this mean? So there will be lack of hygiene. So remember students, scabies is a water washed disease. It is a water washed disease. From your SPM knowledge, if you remember, the diseases which we can easily reduce the incidence by simply making use of the water to wash the body. They are called as water wash disease, and scabies is one such disease. And because of the intellectual disability, what happens is there will be reduced competency in proper hygiene measures, because of which this might is going to increase, and it is going to be seen in the millions, because of which this special type of scabies, which is called as Norwegian scabies or crusted scabies, is going to be produced. Okay, so the answer here is crusted scabies or Norwegian scabies. Okay, so that's it in this video. I hope this was helpful. If it was helpful, do hit that like button, and also do subscribe, and also share this to your close friends, and comment in the comment section what could be the answer for this this theory type of question which was once asked in the MGR University. And let me tell you the answer, it is psoriasis. So if you want me to make a video on psoriasis, type in the comment section psoriasis. So that's it guys. So read from these books so that you are going to remember this till the exam time, and you can join all my Telegram, Instagram, WhatsApp groups. The links are there in the description in the first comment. So thank you so much. Happy learning. Sarvam Sri Krishna Arpanam. Sarve Jana Sukhino Bhavantu. Bye bye.